Thank you for having me. I am a pacer, so I'm not going to spend as much time behind the podium today. I look forward to what you're going to learn here today, not from me, because if you're expecting me to tell you something new, you're probably going to be disappointed. What I hope to do maybe is put a little bit of a bow around some of it, put a couple of ideas in your head, and give you a couple of things to be looking forward and start moving towards in order to accomplish some of this. But in your panel of speakers, in your listening to patients, in your opportunities to talk about where technology and frankly not technology is going is a powerful thing in figuring out what patient engagement is. So you notice the title of my slide. I call it the Healthcare Advantage because I believe it is an advantage to healthcare when you talk about engaging patients. But you'll also notice the subline, people, engagement, and experience. Those are different things. So I'm going to put up two slides. I'm going to give you a definition, and then I'm going to try to make my case a little bit for why I think the way I think, because I've created the reason I think the way I think, and by the way, you don't have to agree with me. There's nothing about this that says you have to agree with where I stand on things, but I'll tell you how I think and why I think a few of these things. So the first slide, it's not about technology. So how many people in here are traditional caregivers? The vast majority of your time is spent taking care of patients or being involved in that process that's not really technology. Okay? And how many of you would consider yourself technologists, part of the HIT team, somewhere deeply involved in technology? Yeah, that makes sense. Anybody offended by it's not technology? Oh, I thought maybe one of you would be. Give me a good debate going on. No, the point being, to my second statement, there's too much technology right now. The problem is that we've not done a great job, certainly as healthcare. I'm not sure everybody has either, but certainly as healthcare, we've not done a good job of putting the technology together in a way that actually matters. And that sounds offensive because we put in EHRs, your Epic, your Cerners, Meditechs, others. You know, we put in all these fancy systems. But have we really done it in a way that is benefiting people? Now, I want to make a definition of people, and I don't even agree with my first definition completely because it's not broad enough. But start off, instead of patients, start thinking about people as the people that are simply around you in some form. They could be in the community that probably have no relation to your organization. They might become your consumers, pharmacies, other things that you have, maybe your labs or certain services, but you're really not treating them as patients. You might be holding a medical record. And then you have traditional patients, of which the EHR is probably holding a tremendous amount of patient information, medical information on that person. But think of them as people. But expand the people definition, which this does not do, but I do. Expand the people definition to also include caregivers. Doctors, nurses, home care, all the other people that are involved in the process of care. They are all part of engagement and experience. And let me define engagement and experience, right? Engagement for me is that thing that connects them to you. The reason why they stay attached to you as an organization, why they might look to you. How are you engaging them? How are you getting them to interact? How are you getting them to be healthy? How are you getting them to respond? How are you getting them to leverage whatever it is you as a healthcare organization do? Experience is what you create around that to say, well, how do I actually do that? You could call that digital. I think there's a human aspect of that. It's not always technology and digital. But how are you actually now using whatever's out in the world to actually create that engagement? Because if you say, I want to engage you, but you don't ever reach out to them in some form. By the way, that experience could be billboards. I don't care. But there is an experience around this whole idea of engagement and how you engage. Okay, how many of you know the 10-point pain scale for healthcare? Oh, come on, more of you know than that. The duh, right? All right, so I have to tell you, this is my funny version. I didn't create it. Don't give me credit for it. But I like it because it takes away the smiley faces and put it in a little more context of something that's more meaningful to me. I personally like the mauled by a bear or a ninja. Could be a ninja. Or I'm just totally unconscious, in which case you didn't need a pain scale to know that. So I think this is funny. But here's what's not funny. And this is what drives my opinion of how we need to go about patient engagement. Do you realize this is the healthcare system as seen by our government? This is what we've created. Now, I'm not saying right or wrong. This is not a political statement. This is simply healthcare. Do you see where the patient and the physician, the two most important, right, in the conversation of taking care of care, do you see where they are in this chart? It's no wonder that healthcare has some issues. And you can define what issues mean to you. But healthcare has some issues. This drives my thinking because somehow we have to figure out how to elevate the people that are giving care. This chart calls out physicians, but we know there are a lot more involved than just physicians. And people. We have to figure out how to get them higher in this equation. The other problem that most healthcare organizations fix, which derive from this chart, is these are all the people that are knocking on your door because of some regulatory issue. So while you would like to be really nice to people and take care of them, somebody's trying to keep you from doing that, whether that's privacy, digital security, compliance, whatever it happens to be. Somebody's trying to keep you from doing what you really would like to do for patients. We have to find our way through this. By the way, it's possible. This chart just drives me nuts because I don't know how anybody, I was a CTO, I don't know how anybody actually navigates through this and stays legal and compliant and never does anything wrong. I think it's nearly impossible. How many of you know about the Winchester Mansion in San Jose? Everybody? Anybody not know? A couple people don't know? Okay, let me describe it for you real quick. Winchester rifles. The Winchester, Mr. and Mrs. Winchester were afraid that the spirits of all the people that their rifles killed would come back and haunt them and kill them. Seems reasonable to me, right? Mr. Winchester died, but Miss Winchester consulted mediums and said, how do I not get killed? And the medium said, keep building on your house. You'll keep them confused. And by that confusion, they won't kill you. Sounds reasonable to me. Not. I'm sorry? The contractor said that, I think. They hired the medium. He said the contractor said it. It's probably true. By the way, somebody corrected me the other day when I said there was no architectural plan here that says there was an architectural plan. It was to have no plan. But the point being is that there was no plan. And for 38 years, they built on this house. You can see some of the stats up there, things that went to nowhere, just dramatic confusion by design. So you see to the side over there, that's the current, that was the latest, because they haven't found everything, but that was the latest architectural diagram of the Winchester Mansion. I will suggest to you that this is both how your IT organizations feel, because they have all of these different systems and they've spent an awful lot of time trying to figure out how to connect them all together, move some data around and make everybody happy in the process. Great complexity. And it's also how most patients feel looking at healthcare. They don't know what door to go into. Some of the doors don't lead where they need them to go, right? Both from a facilities perspective, from a service perspective, from an information perspective. They don't know necessarily where to go because we don't present a united front from a healthcare organization's perspective. Much like we're talking about from the Olympics perspective, right? How do you bring some of this stuff together so that things are known where they need and you can simply go in the door and find what you need to find in something simple? So I submit this is the way we look today. A lot of it was driven by the previous two slides. Some of it was just driven by the fact this is the way we grew up. Intermountain Healthcare, I'm partially to blame. I was there for 19 years. I can blame myself for a lot of the complexity that showed up. But I also went to create the Transformation Lab. Let me tell you why the word Transformation Lab and not Innovation Lab, because every other healthcare that has one calls it Innovation Lab. It wasn't about creating something. It was about changing care. The point was, how do you take doctors, nurses, patients, technology, and go change care? And that's what we wanted to wake up every morning and go into the lab and think about. How do we actually put the pieces together somewhere different? Yeah, did we make something here or there? We did. There's always a little development that you have to do around to make all the pieces stick. But most of the technology tends to be there. Because what people want is this. How many of you would be happy with your airlines or your hotel if you had to go into different places to get this scheduled and then go over here to change this, or to go over here to see this or that? They don't always do a great job, but they try really hard to make it as seamless as possible, as close as possible, to have everything notify you in the same way as possible. There's almost always a gate agent. There's almost somewhere in the concourse somebody that you can see to get something changed if you have to. That's the way we want it to work. Nothing's perfect. Banking's not perfect either. But these are things that our people, patients, by the way, physicians, nurses, caregivers, all expect it to work. They don't want the complexity. In fact, it makes their job harder, and I would argue that it probably impacts care. It impacts care from the patient's perspective, where they don't get care the way they need to and when they need to because it's more difficult and they avoid it. My wife is one of those. She is a avoider of healthcare because everything from getting it scheduled to the hassle for going in to seeing the bill and figuring out how to get it paid, and we're on the road all the time, so bills never come to the right place. It's difficult. But also from the perspective of how nurses and doctors and other caregivers actually care for you. Because of right information, right time, easiest way possible. They spend more time pecking on the computer sometimes than they actually do taking care of patients. Now, some of you would argue that. You try really hard. But we've put a lot of complexity on you for the things that we're asking for you. I do believe there's a future where we'll figure out more automated patient documentation, where the activities that you're performing will self-document, and we'll figure some of that out in the future. Not there yet. Holy grail of mine. I hope we see it in my lifetime. But certainly between computer vision and AI and other things, I think that will find its way to help that. But there are things that we should be doing to create this vision, this stars aligned, as I would call it, opportunity. So let me just tell you a few elements. There are a lot of slides to this that aren't in here. So I'm going to put up kind of 3 slides from 3 perspectives of elements of engagement. And they're the very high-level kinds of things. From your patient's perspective, there are some things to do around encounters. There's some things to do around being care and how you access data. And those are just some key things that you ought to be dealing with as broad brushes in how you go about patient engagement and creating the experience around that engagement. I say the same thing around clinical staff. They're just things they want. They're things they need. And so around I call it technology. They're just some things that the technology can certainly help them with. Being more part of the care team and providing that. I use the word transparency. I don't know if it's the right word there, but that idea that we're being as transparent as possible as to what's going on, what they need to know, what the patient needs to know, and providing that back and forth. But lastly, part of people is your organization. Your organization also needs this greater engagement and experience because it's all part of providing care. Billing is an organizational problem. We don't necessarily call that part of patient care. But billing and getting that solved is an organizational issue that impact how people feel about you. So we need to be working on how we bring the organization in similar kinds of broad brush capabilities. How do we bring that to care and engagement? Another thing I'd like to just make sure that you fully understand, I believe there's a human component to this. To get this done, it takes medical procedures, medical process. It certainly takes technology, but it takes humans as well as the digital side of this house. Until AI catches up, and by the way, I'm a believer in AI and DI and MI and pick all your other I's that you want to, whatever the buzzword is today. I believe those things will certainly trim how much human interaction sometimes we have to have on some things. But certainly for the foreseeable, probably in my lifetime, there will always be humans involved in the overall care of patients. Agree, disagree? Agree? Good. So when you're thinking about how you do patient engagement, remember that technology supports keeping the humans involved. We often discharge people from the hospital, and unless you're in some ology, cardiology, or something that's following you for some specific reason, we lose you. Your primary care physician, I've got one. I see him once a year. He never talks to me otherwise. Not his fault, by the way. Not because he's not a good doctor. Not his job. Not only is it not his job, he has no way to follow me. There's no engagement in my care going on, so there's nothing for him to know. And there's no way for him to reach out to me and involve me otherwise. So he assumes everything's fine. Now, this is a real example for me. My wife has had 7 surgeries, and I'm a diabetic. Surprise. So we use care from 2 different perspectives. As a diabetic, you would believe that my physician would want to follow me fairly closely because exercise, what I'm eating, all these other things, right, are all impactors to my health. To be honest, and I don't say this lightly, we had this big conversation in a healthcare briefing I did a couple of weeks ago where we had physicians and nurses and other caregivers in the room as well as technologists. I don't care. That sounds harsh, and I'm the one that's going to pay the price for it. But I like my quality of life. I'm happy. And the things that I think I'd have to give up, I think change my quality of life. So the question is, what triggers me to do something different? Well, my physician will never figure it out because he's never in contact with me. He's never engaged with me after the fact to know. My wife, on the other hand, extremely healthy. Overweight like I am, but extremely healthy. But her 7 surgeries have been based on a botched first surgery that happened in the 80s, and it's been an ongoing problem to clean this up. But in one particular case, and I know this sounds gross, they literally made about 1.5 foot, 2 or 3 incision, went in, fixed the problem, and left her open. You close the innermost part, and you basically leave the rest of it open, about yay wide, yay long, and you heal from the inside out. Now, by the way, that's a medical way of solving a problem, and we were okay with that, except when we got discharged from the hospital. They supposedly discharged us to a home care, wound vac, all these things that you have to do, yet we really weren't taught how to use the wound vac. Oh, well, home care will come take care of you. Nobody in home care knew how to do a wound vac on a wound that big. They're used to, maybe knees or something like that are relatively small. They didn't know what to do with something this size. And then we had to go visit somebody 40 miles away and have an office visit of which they tore the thing off, the packing and all that, and threw it away. And we, the expectation is they'd look, see how things are going, and then they would pack it all. But they didn't have bandages that were big enough. The incision was too big. Well, what do? You just throw everything away, and now she's got this big thing, and you can't put a bandage on it? Because we don't know. We don't make the connections between the two. We don't follow people after the fact. And by the way, the physician that did it, very nice guy, but that surgeon was out of the picture. That hospital was out of the picture because they had discharged her to home care. They forgot to check that the home care was ill-prepared to deal with somebody like that. She was well otherwise, but this is a huge problem. They ultimately wound up bringing in somebody from another place and keeping them in the area for a while to deal with some of these complex problems. But I, as a patient, I had to figure this out. I had to order medical supplies on my own from somewhere else to get something that was big enough to handle this problem. I had to go between hospital, surgeon, charge nurse for that surgeon, and my home care to try to get somebody to take care of my wife. Why is that not part of a patient experience where these things are dealt with. It's not just about creating a mobile app and letting them see their mobile record and letting them maybe make a schedule. By the way, very important things. Do not get me wrong. But when I lose the patient in the process, you have lost the ability to create engagement, and you've lost the ability to create an experience that if you care about bringing them back to your organization, that will bring them back to you, and to make sure that they are well taken care of, because if you're trying to manage a population, you absolutely want them to be as healthy as possible. And if anything's going wrong, you want them back somewhere where they can be taken care of or somebody's looking after them for that. But there is a human component to that. Somebody needed to have some tickler, as I used to call it. I'm old, so we used to call it a tickler file, right? Somebody needed to have a tickler or a reminder or an alert or something that popped up and said, go check on Pam. Make sure she's getting everything that she needs right now in order to do what she needs. Is she having any problems? A human probably needed to check with home care and said, look, this particular case, going to need some of your bigger items and, going to need a little more intense care than well-meaning people. Very seriously. Everybody's well-meaning in this process. And by the way, for what they are trained to do, excellent at their jobs. We threw something at them that humans need to help coordinate that. So as you think about what is engagement, what is experience, and when you think about people in that conversation, do not lose sight of the fact that at this point in history, humans are part of that. Digital is a way you can do that communication. That's a way you can do telehealth. It's a way you can get them information. It's a way you can collect data. But it isn't everything. Now, for the techies in the room, I argue that we can handle patient experience kind of easily in a very complex world. There's a lot of detail under this, so the slide may not make sense to you, but the end game for me is that I believe as technologists that there is a technology infrastructure that we can put in place, and that when we're done with that infrastructure, we're 70, maybe even 80% there for the vast majority of things that we want to do in patient engagement and experience. And it all starts with freeing the data from its silos and figuring out how to raise the complexity out of your EHRs and lab systems and scheduling systems and billing systems and all these other systems that we have. There is a way to do this. And there is a way to do a significant amount of it once so that you can spend your time going, how do we want to engage them next? That's 20 or 30%. How do we engage them next? That's 20 or 30%. How do we engage them next? That's 20 or 30%. That is doable. And in that model, it's very difficult sometimes for us to get there because we have all these complex systems and they're all silos and they're all Winchester mansions. But there is a way to rise above that and say, I will navigate you through this. I will get you what you need to know. If you go visit the Winchester mansion, there's somebody that starts you in the beginning and takes you on a tour, and they get you through this Winchester mansion. They don't give you the map and say, go have it. Right? So there is a way around this. And so this slide's only my view of the world, that we can create building blocks in such a way, and I know we've talked about that for a long time. I do believe there are plenty of technology sitting out there now that will let us do this in a way that we can be as flexible as the business and our people need us to be. And by the way, you can use this to make physicians happy. You can use this to make nurses more efficient. You can use this to follow people before they become your consumers, before they become your patients, and after they're your patients. So, the mantra that most people have ever heard me say this, have this talk before, will hear me say is that there's no one solution. You cannot go buy a package today that does engagement and experience, period. Plenty of people will sell you front ends and digital, and by the way, I'm not saying they're good or bad, that's not the point. People will sell you back ends that do various things here and there, but no one sells you the entire solution because it's based on humans, it's based on technology, and it's based on a lot of piece parts that have to be put together. It really becomes a solution of solutions. So the first thing you have to figure out is, well, what solution do you really want? Where do you want to go? What is it you're trying to be? So I will give you my recommendations. First, be a thought leader. I go to a lot of clients in my current role, and many of my clients tell me that they cannot influence the organization to go do some of this stuff. They don't have the power to do it. And some of the organizations, I would say that's probably true. It's just the political culture that exists there. And they just don't want to be forward-thinking. They don't think they have the money. They don't think they have the need. I will argue some of them that the IT world has certainly created a persona around them that they are no-sayers, not yes-sayers. And so being thought leaders and coming out and saying we should be going that direction, they get ignored. But I really believe that CIOs, CTOs, those C execs now, their new role, if they're going to stay around, are really becoming part of where the business is going. Stop talking tech, start talking where the business is going. And in that conversation, you have the chance to be a thought leader. I don't care where your state is in the IT organization or in the healthcare organization. You can begin to move these thoughts up. Here's how, as a CTO, I got things done at Intermountain. I rarely held a big meeting, put a big PowerPoint, and said, hey, this is something we ought to go do. I did two things. I gave whatever my thought was a name. Simple, sometimes fun. So in my current role, the project's called Unicorn. I won't here tell you what unicorn mean and how we came up with it and what the issue was. Jerry is very well aware of it, and I'll be happy to tell you in an offline or over a, I don't drink beer, so Coke or Pepsi. But we call it Unicorn. And then I start telling people where I have the opportunity, whether that's the elevator pitch or just an opportunity. I start telling them what it is and what the vision is, the thinking. So I'm old. We did SANS before SANS were popular. But when SANS came in, and I'm an old IBMer as well, not working for IBM, but I've been one of IBM's large customers for a long time. When Sharks, any of you old enough to remember the Shark that came out? Had the little fin on top as a disk system, right? But it was a Shark. And people didn't want to go to it because it was all new and funny and different. But you start calling it Shark, and then you tell them what it does for them and how cool it is and why, but not technically, right? They're going to get higher availability, everything's going to be faster, and by the way, when you need something, I can do it like that. I like that. By the way, I can put all these things on there and you can go down the list. And you know what? As I would go with other things and say, that's going to be on the Shark, right? They don't remember what the Shark is, but they know they like it, right? So you can be thought leaders by starting to have the conversations and getting people to hear your thinking. Put a cool name on it, and then just let it bubble up. And when you have the chance to talk to various people, whether that's your staff or whether that's people up that chain, just share your thoughts. It'll be interesting because I believe a lot of the C-levels, a lot of the execs, a lot of people in the opportunity are really looking for people who have a vision of something and of something that actually makes sense to them, that actually is going after the problems that they have. Be a thought leader. And don't give people a Winchester mansion. If your way to solve this is, well, I got a system over here, and we can create an app, and they've got the mobile app for that. Epic, CERN, everybody has a mobile app for that. Then we got the system over here where we can do scheduling. If you don't do it in your EHR, then I've got the system over here that can do that. And I got the system over here that can do that. And feedback loop, now we send them over to SurveyMonkey, and then we do that over there. And by the way, if you want to do telehealth, then we go out to American Well, or we go to somebody like this, and you got 10 apps on your phone. Doesn't work today. So don't give them Winchester Mansion. Find a way to make it look and feel like a cohesive organization. And if you happen to be partnered, many of you in this context, partner with each other and are less competitive in certain spaces and say, you know, these services, we go over here. Well, figure out with that partner how you get them over to that service without them feeling like they've been shoved off to another healthcare system. Don't lie to them, but make it painless for them. And by the way, make it painless for them to come back, because you don't want them to go over there and stay over there. You want them to find their way back to you because you gave them great service. So give them a way back. Don't give them a Winchester Mansion. I know it sounds like a duh, but you just be funny how many my customers, I'm going to do everything in the HR. Well, that's fine. Can you do everything in the HR? Well, no, because I want to go collect IoT data. I want to go collect this. I want to give them healthy. Well, it's not there yet today. They're working on it, but it's not there yet today. So you really can create a Winchester Mansion in a hurry. And do remember this. Data is king. And as many of you have heard this before, and it's been harped on, and you've all the buzzwords around it. Here's what you want. You want to know everything about that person that you can legally and ethically know about that person because it will make a difference in their care somewhere in the future. It may not today. You may not know what to do with it. But having the inroads, whether that's into their Fitbit or whether that's into their diabetic meters, whether that's into wound care pictures, whether that's into their healthy, Lordy, people ride bikes, people run. Well, you know what? Create something that engages them into something you can do to help them along that way. One, it keeps them healthy, but two, that information's useful. And because here's what's going to happen in the future. That data is going to figure out what the trigger is for me to start being healthier. For my wife, the trigger was simply the doctor would not do the surgery until she got to X. It was a quality of life problem for her. She had a bowling ball on the side, and she simply had a poor quality of life from that. That was a trigger. It mattered not. She lost a significant amount of weight. She cut out on the, Cokes and things like that. She basically got herself where she needed to be. Because for her, that mattered. I don't know what mine is. We were having this conversation the other day, and physicians were in the room, and they were kind of like, don't you know how bad it is? Yeah, you can tell me all the crappy stuff, but it still didn't matter because I'm happy. I'm extremely happy. But the data will tell you at some point. Now, the other thing we had that same conversation was we don't quite know how you actually look at the data to come up with that answer, right? Figure out personal triggers that make them act differently. But you'll never know it without the data. And if you get people who are starting to create the trigger, okay, my wife changed. Well, what was the data around her that actually caused the change? What was that thing that caused the trigger? Data's king. And if you ever expect to do cognitive AI, DI, MI, whatever it happens to be, if you ever expect to do that, you can't do it without the data. Period, end of story. And when they enter your organization, if all you know about them is name, rank, and serial number, then you are simply not going to take best care of them. Now, we would all love to be sharing all data. That's why we have health information exchanges, etc. And we share some amount of it, but we only know so much. How many of you basically interact with patients via the EHR portal? Good thing, but it's not all of it. There's so much more to be done. And my wife will tell you, and she uses portals on 2 of the big EHRs just because she's got 2 different sets of physicians. And she hates them both. I'll tell you what makes my wife madder than anything when she goes on a website and it says, you go here to register for this or do this or pay this, whatever, and you can't find the blooming button that says, and it's buried somewhere. The same thing was a podcast we were looking at the other day. And it said, go to this website and hear the podcast. Well, you have to create an account. Okay, create an account. Then you get to the page. Where the heck's the podcast button? I could not find the podcast button. And I'm not a stupid guy. I'm not the smartest tool in the shed, but I'm not the stupid guy. I couldn't find it, and it just drives her nuts. Right? Create something that actually matters, and it's not just about portals. I've already talked about collecting the data, right? Get on the train of collecting data. And there are very ingenious ways about looking at how to collect data. By the way, there's a lot of community data that's not patient-specific, especially in California. There's a lot of interesting information. If you just collected that data and begin to infer it on your patient population, we had one person in that briefing that was talking about cancer. And there's a cancer hospital in the vicinity, right? But many of their patients are going up towards LA to go to the cancer hospital. Why? Did they not know there's a cancer hospital here? They put up bulletin boards, billboard. Drive people back. But just the community data alone was telling them things about their patient population they didn't understand. And it's not patient-specific. Data's king. Now, everybody has an analytics program. Every one of us vendors sells some kind of analytics capability. Cool. How many of your analytics actually give you actionable insights and intelligence? Having an analytics program, and by the way, I don't use analytics as how we do it. What you want is intelligence and experience. and insights. And they have to be actionable. And it's a duh. But so many of us, as I look at clients around the country, simply don't look at analytics that way. Somebody wants a piece of information, but it's not necessarily the actionable information. It might be. They're asking for it, but they're really doing it because the various departments in the organization are asking for some piece of information. Build your analytics organization to create actionable insights and intelligence. We've talked about triggers. I still want to find the one that triggers me because I really want to do it. I really would like to live long and prosper and grow old and grayer than I already am. But what are those triggers? I don't know. And engage people before they become your consumers and before they become your patients. There's a powerful story in that. And it really is about collecting and knowing the people so that you, number one, not only take good care of them, we all want good outcomes, but if you care about staying in business, if you care about bringing people to your organization, whether you believe you do better care or whatever, unless you have a captured market, it's the way to connect to people, for them to know you and to want to come to you. Because while data is also king, in the patient world, the patient's king. And we don't like to say it, but it really is. They have choice. And whether you like where the law has been or not, and this is not a political statement, you can side with or like it or not. It pulled off a Band-Aid that made things hurt, so now we have to address it. And number two, it's made people, patients, more important and king in the process. They have choice. They can go to different places. They will go, not because you put a billboard up and say, I'm the #1 cardiac hospital in the country, or I'm top 10 of this, or I'm top 100 hospital in the. We don't generally make our choices too much toward that. It's a factor. We go for either convenience, we go because we like the physicians, we go because, in case of children, there might not be a lot of children's hospitals in the vicinity. There might be a variety of reasons, but those reasons create choices, right? And now you're against everybody else in those choices. So, engage them early. And this other one I think is the big important one here. If you don't do anything else, if you look and say this is all great, the next conversation for the next number of hours is all great, but my organization has no money or no stomach to actually go accomplish this, it's politically complicated, no marketing's going to do it. By the way, I feel strongly marketing is a good thing in a company, even in healthcare. Certainly can be your friend in this process, but they're not it. They don't know healthcare in the sense of providing best care. Those are physicians and nurses and other people. And technologists know how to help move that along, and then you have the human factor. But you ought to be working on the plan. If you're not engaging, whether you can do it yourself or you need somebody outside to come in and help you, whatever it happens to be, get on the plan. And that's a human plan, that's a technology plan. Start putting a plan. Why? Because number one, you don't want to be behind. But I believe, as an old technologist, CTO, and an architect guy, every decision I make going forward, I should be making in context of the plan. It doesn't mean I don't need it, doesn't mean I won't buy it, doesn't mean we won't install it and it won't run on its own, but do it in context of the plan. Otherwise, you're wasting money. And you might get lucky and it all be part of the plan. You just don't know if you don't have a plan. And it's going to take us years to get there. We're talking about what we're talking about with Olympics. What we're saying, we got 10 years. It's going to take us 10 years to get to that point. Great. They're on a plan. They're looking at a plan, right? How do we make our mark between now and 10 years from now? Well, your organization should be making that mark now. You should be thought leaders and helping them think about how this strategy works, because you need to know how, if you're technologists, you need to know how you're going to change your technology infrastructure over some course of time and spend your money correctly. What do you need to be doing now? What is the thing to be doing now? What is the thing to be doing tomorrow? What is the thing that you're going to do in 1 year, 2 years, 3 years, whatever it happens to be? And by the way, the time frames will change. I assure you, if you made a 5-year plan today, that is a 6-month plan now. I always said, so as CTO, right, you're supposed to have a crystal ball. I'm supposed to be looking 2 to 5 years out. I looked 2 to 5 years out. I looked at my crystal ball. My crystal ball was always broken, had duct tape around it, and went into the shop routinely to try to get fixed, and always came back in the same shape. Cloudy. That's okay. Because at least I had a 6-month plan. At least I could see 6 months in the future. Put a plan in place. And I would say the number one thing I'd be doing right now, if I were in an organization's shoes, is working on the plan. Whatever it is. And your organization will define what matters to that organization. I know some that are, I'm in this box, this is all I plan to do, so that plan revolves around that box. I know some that are like, want to take over the world, and so their plan is world domination, and okay, we'll work on that plan. And everybody in between, but work on the plan. And then you can execute. Then you can socialize the plan. It will take you a couple of years probably to get the whole thing socialized and get funded anyway. So start talking to them. That's part of being a thought leader. Have some plan that you're willing to change, that you can start sharing, that you can put a name to, so you can start having conversations. Because the conversations are what matter. Last thing I'll say here is, don't forget governance. This idea that we as IT people can do this on our own is nuts. Now, some of you go, well, yeah, we've got committees of this and that. Yeah, there's a governance structure. It isn't just advisors. Let them be part of the process because they're part of the organization. And by the way, there's more than one. Data governance is one thing. Clinical governance is traditionally there, but certainly another thing. IT governance is there. And then there's governance of governance. But don't forget to govern to make sure that it doesn't go haywire. Because when people are bought in, you pretty much get your way. I will argue that every time I had a conversation with somebody, most people didn't disagree with me. But it was easier to do it in a conversation. And it's easier to do it in governance. It's easier to get her buy-in and help do it. So don't forget the governance. Okay? You had a slide. Yeah, okay. Questions? Any from me?